Good morning. Let us continue with the renal system and the syndromes which we have seen already. The syndromes which we have already covered are the nephritic syndrome and the nephritic syndrome, and what are the histopathological entities which cause nephritic syndrome. It is the number one is your the post-streptococcal glomerulonephritis. Yes, diffuse endocapillary proliferative glomerulonephritis. We have a membranoproliferative glomerulonephritis and mesenteric glomerulonephritis and mesangioproliferative glomerulonephritis. These are the four glomerulonephritis which present clinically as nephritic syndrome. The next syndrome, before going into the next syndrome, let us see something which I found it very nice and I would want to share with you people. If you tell the truth, you have the infinite power supporting you, but if not, you have infinite power against you. And I think this is very true, and most of us should remember this. And now, so today this class is all about nephrotic syndrome. Do you remember what nephrotic syndrome was? Nephrotic syndrome, it is a massive proteinuria which is greater than 1. Yeah. It is a massive proteinuria greater than 3.5 grams per 24 hours of urine. And when you are having massive proteinuria, when lot of protein is being lost in the urine, what happens? There is decrease of albumin in the blood. Hypoalbuminemia less than 3 grams per deciliter. When there is hypoalbuminemia, there is a decrease in the oncotic pressure which leads to edema. And finally, the other entity of this syndrome is that you have hyperlipidemia and lipituria. This is what is nephrotic syndrome. Yes, and this proteinuria, it is most of the time selective, in which only the albumin and the transferrin with the relatively low molecular weight proteins are being lost. But your high molecular protein, especially your globulins, are not lost. But there are also certain proteinurias where it is poorly selective, and in those cases even the high molecular weight globulins are being lost. Now, what is hyperlipidemia? Whenever there is an increase in the cholesterol levels in the blood, it is called as hyperlipidemia. And this increase is because of the increase in the LDL, VLDL and the lipoprotein and apoproteins. These are the ones which increase in the cases of nephrotic syndrome, whereas HDL is decreased in your hyperlipidemia in cases of nephrotic syndrome. And what might be the cause of this hyperlipidemia? It is because there is an increased synthesis of lipoproteins in the liver, and there is an abnormal transport of these lipids, and then we are having a decreased catabolism of these lipoproteins. That is the reason why we are having hyperlipidemia in the cases of nephrotic syndrome. Then, what is happening to the lipids which are being leaked into your there is hyperlipidemia. So now what happens when there is hyperlipidemia? This lipid is leaking against the across the glomerular membrane, and it causes lipiduria. This is the other feature of your nephrotic syndrome. And because of the loss of the proteins and because of the loss of immunoglobulins, these cases, nephrotic syndrome cases, are susceptible to infection. Not only infections, we are having another complication as well, because proteins include even your antithrombin and the other proteins in the body. When they are being lost, you are having an increased propensity for development of thrombosis, especially renal vein thrombosis. This is another complication of your nephrotic syndrome. So, two complications. One is susceptibility to infections. The other one is renal vein thrombosis. These are the two complications of your nephrotic syndrome. Now, what is nephrotic syndrome? The primary thing we were talking about is massive proteinuria. What is this massive proteinuria? It is because of the loss of albumin. This loss of albumin, it is causing hypoalbuminemia. Hypoalbuminemia is leading to a decrease in your osmotic pressure in your blood and in the capillaries. This is leading to generalized edema. What is massive generalized edema called as? It is called as anasarca. And when we are having a hypoalbuminemia, there is a decrease in the albumin globulin ratio. When there is generalized edema, what is happening? There is a decrease in the plasma volume which is present in the vascular compartment. This reduces the GFR, it increases aldosterone and decrease natriuretic peptides. What are all these three doing? When this is happening, there is salt retention, salt and water retention. This salt and water retention, it is increasing the osmotic pressure. The oncotic pressure is decreased and osmotic pressure is increased, which leads to again edema. So a vicious cycle continues. If we look at the clinical course of the nephrotic syndrome, they are not similar. Just like how we saw in the nephritic syndrome, this nephrotic syndrome is also not a homogeneous disease. Each case has different histopathology. Now, this class we are going to look at what is the histopathological change which occurs in the clinical manifestation of nephrotic syndrome. So, now here primarily we are having 4 lesions which cause nephrotic syndrome. We divide nephrotic syndrome into primary nephrotic syndrome and secondary nephrotic syndrome. Primary nephrotic syndrome, we are having 4 entities which cause nephrotic syndrome. The first one is the minimal change disease. The second one is your diffuse mesangial hypercellularity. The third one is your focal segmental glomerulosclerosis, and your fourth one is the membranous glomerulonephritis. Now, in these 4 cases, the first one, which is the minimal change disease, is the most common type of it is the most common in children. Almost 65% cases of the nephrotic syndrome in children are because of the minimal change disease, whereas only 10% in the adult nephrotic syndrome. And focal segmental glomerulonephritis is the most common cause of nephrotic syndrome in adults. 35% cases of the adult cases is of nephrotic syndrome is focal segmental glomerulosclerosis. The same way, 30% of the cases of your adult nephrotic syndrome cases are due to membranous glomerulonephritis. These are the primary causes of nephrotic syndrome. We also have systemic diseases causing nephrotic syndrome. Those are diabetes, amyloidosis, SLE, and many drugs and infections cause your nephrotic syndrome. These are the secondary causes of the nephrotic syndrome. Now, let us see what is minimal change disease. Previously, they called it as lipoid nephrosis. The hyperlipidemia actually led to lots of lipid coming into the urine, and if you into the glomerular filtrate, in fact we should say, okay, when you are having a lot of lipids into the glomerular filtrate, and when it comes into the proximal convoluted tubule, where everything which is necessary for the body is being reabsorbed. That is what happens in your proximal convoluted tubule. So even these lipids are being reabsorbed, and this was actually capsulated and vacuolated and present in the tubular epithelial cells. So that was the reason why they called it as lipoid nephrosis previously. But later on they found that there is no change histopathologically, and so they called it as minimal change disease. Now, minimal change disease, it is the most common cause of nephrotic syndrome in children, and usually the peak incidence is from 2 to 6 years of age, and then sometimes this is following the respiratory tract infection or because of immunization. And the most characteristic feature of your minimal change disease is that they respond to corticosteroids, and in some cases they resolve completely. What is the etiopathogenesis? It is thought to be an immune dysfunction of the T cells with circulating cytokines, and also it affects the visceral epithelial cells and increases the glomerular permeability. When it comes to light microscopy, that is H&E stained sections, your glomerulus is perfectly normal. You don't find any change in it, except that the cells in the proximal convoluted tubule are filled up with lipid vacuoles, just like what you see in your fatty liver. The cells in the proximal convoluted tubules, that is the what are the tubular epithelial cells made up of? It is the cuboidal cell. That cuboidal cell is filled up with vacuoles having this lipid, and then that was the light microscopy. So they went on to look into why this proteinuria, massive proteinuria is occurring. So they went and studied the electron microscopy. In electron microscopy also they found that actually they found that the basement membrane was normal and there were no immune complex deposits in these cases, except that your visceral epithelial cells, which were called as podocytes previously. If you remember, in the previous classes we called them as visceral epithelial cells, also called as podocytes. Why? Because they were having lots of food processes or the pseudopodia, which are actually engulfing or encircling your basement membrane and the endothelial cell. Those food processes are effaced. So this is the only pathology in your minimal change disease, effacement of the food processes. And immunofluorescence found no immune complex deposits in this disease. So normal basement membrane and absence of proliferation. Look at this picture. These are all your tubules. See, these are all your tubules. Yes, and this is your glomerulus. These spaces are all your capillaries, right? And the black dots are the nucleus of the endothelial cells, and the cellularity is absolutely normal, and the basement, this is actually a PAS stain which is highlighting the basement membrane. This red line is all your basement membrane, and it shows that the basement membrane is also not thick. Yes, so the normal basement membrane and absence of the proliferation. It is a normal glomerular membrane in light microscopy. Yes, the same thing again here, the PAS stain, the tubules showing the basement membrane. Yes, this is your Bowman's capsule, this Bowman's space, and this is your glomerulus, and the basement membrane is normal with normal cellularity. Only thing which we find is the effacement of these food processes. Do you remember how it looks in the normal one? This is how your food processes are of the visceral epithelium. This is the visceral epithelial cells, and these are the food processes. They get effaced because this visceral epithelial cell is swollen, and all the food processes are getting into the cell. When there is an edema, what happens? All the food processes get obliterated. This is only thing which happens in your minimal change disease, no other feature. Here also you find that there is loss of food processes. You usually have food processes. This is an electron microscopic picture actually. Yes, the food processes, these are the pseudopodia, and they are usually effaced in the cases of minimal change disease. And now what happens in the minimal change disease? Despite massive proteinuria, though there is a lot of proteinuria, however, the renal function remains good. This is not the case with nephritic syndrome. If you remember, nephritic syndrome can have azotemia and oliguria, but these cases of nephrotic syndrome with minimal change disease histopathologically, nephrotic syndrome is your clinical manifestation, whereas when we say that it is a minimal change disease, we mean what is the lesion and how does it look like on histopathology. Here, though there is massive proteinuria, renal function remains good. There is no azotemia, and usually proteinuria is selective, and 90% of the children will respond to corticosteroid therapy, and they usually resolve completely. And when it comes to adults, they are slower to respond, but even in adults, the long-term prognosis is quite good in these cases, minimal change disease. The next one is diffuse mesangial hypercellularity, but this doesn't qualify to the term of calling it as mesangial proliferative lesion. So if you remember, there is a mesangiocapillary proliferative glomerulonephritis, but this hypercellularity is not up to that level. That is what we need to remember. So it is only diffuse mesangial hypercellularity, which is present in less than 10% of the cases of nephrotic syndrome, and these cases are usually in older children. Remember, minimal change disease, we said that it was a 2 to 6 years age group. If it is older children, this is many times the lesion, and usually along with the nephrotic syndrome they have a microscopic hematuria. Okay, so cases have hematuria, microscopic hematuria as well in cases of diffuse mesangial hypercellularity. Light microscopy shows that there is mesangial hypercellularity, and electron microscopy is obliteration of the epithelial foot processes and electron dense material in the mesangium. And immunofluorescence, the mesangial deposits of, there is a mesangial deposit of IgM. Remember, minimal change disease doesn't have any deposits. This is considered, this diffuse hypercellularity, it is actually considered as an early stage of focal segmental glomerulosclerosis. Okay, so 50% of these cases will respond to corticosteroids. When we said it was, it is the minimal change disease, 90% will respond, but here only 50% of the cases will respond, and rest of them will slowly progress to renal failure. This is the clinical course of cases with diffuse mesangial hypercellularity. The third lesion which is present in the cases of nephrotic syndrome is your focal segmental glomerulosclerosis, and if you remember, focal means few of the glomeruli are affected, few of the glomeruli of the kidney are affected, segmental means a part of the glomerulus is affected, and sclerosis means the capillary is obliterated with a deposition of extracellular collagen. That is what is glomerulosclerosis. So focal segmental glomerulosclerosis, this is seen in 15% of the of children, cases of nephrotic syndrome in children, and 20% up to 20% of the cases of the adult nephrotic syndrome are focal segmental glomerulosclerosis. And again, this case is having nephrotic syndrome with microscopic hematuria, and the recurrence following transplantation in these cases is almost up to 50% of the cases. So what is the etiology in these cases? Most of them are idiopathic, the cause not known, and there is a loss of renal tissue, and in some cases they have seen a documentation of sickle cell anemia and heroin abuse leading to focal segmental glomerulosclerosis, which will present as nephrotic syndrome clinically. Now the disease usually begins in the glomeruli at the corticomedullary junction. So when a renal biopsy is being done and this corticomedullary junction glomeruli are not included, you get a report as a minimal change disease, right? So if you remember, this is the cortex, and all from here to here you have nephrons, and this is the corticomedullary junction. So the nephrons which are close to this corticomedullary junction are the ones which are first initially affected with focal segmental glomerulosclerosis. So when you take a needle biopsy, it takes only this, if it takes only this part, it might miss it. So we require a entire core which will actually include this corticomedullary junction to pick up the cases without fail. What is the pathogenesis of focal segmental glomerulosclerosis? There is an excessive proliferation of the mesangial cells. If you remember, the function of the mesangial cells is nothing but production of extracellular matrix. So whenever there is a proliferation of the mesangial cells and the deposition of extracellular matrix, there is sclerosis of the glomerulus, which means that the capillary which is having lumen gets obliterated because of excessive deposition of the extracellular matrix in the wall of the capillaries, and this leads to glomerular damage. Now, on microscopy, the segmental sclerosis affects one or more lobules of the glomerulus. That is what we mean by segmental disease. So, not only a part of a glomerulus is affected, and on occasion, the sclerosis is seen just opposite to the hilus, and that is called as the glomerular tip lesion. Okay. So, if you look at this, what is it? The sclerosis is confined to this part. If you look at this area, the capillaries are all patent. See the open white colors there, and the blue dots are all the nucleus of the endothelial cells, right? So this is focal segmental glomerular sclerosis. Look at this. This part appears normal, and only this part is sclerosed. Yes. So this is the hilus, and this is the sclerosed part, and this is your normal part. And when you do a special stain, all this blue color is Mason's trichrome stain. The blue color here shows the deposition of the collagen and obliteration. Look at this portion. This portion, it is fully there is full deposition with collagen, and the capillary lumen. These are the capillary lumens. They are all absent in this area. This is what is focal segmental glomerular sclerosis. Here is your sclerosed area. This is all the normal area, and blue is where the sclerosis is occurring. Now the food process obliteration is seen just like what you see in minimal change disease. Then we are having the glomerular basement membrane, which is folded and focally thickened, and then the hyaline deposits are composed of finely granular material. So this is also again a immune complex disease. IgM and C3 are the deposits which are present in the immunofluorescence. Now, what is the clinical course of this focal segmental glomerulosclerosis? Usually it is an indolent course. Okay. So 60% of them will progress to renal failure in 10 years of time. And then if suppose you do a transplantation in these cases, up to 50% the recurrence of the disease will be seen in the transplanted kidney as well. The last one in the nephrotic syndrome, the last histopathological lesion which you find in the cases of nephrotic syndrome is membranous glomerulonephritis. Okay. So, the membranous glomerulonephritis, it is the most common cause of nephrotic syndrome in adults. What is the most common cause of nephrotic syndrome in children? It is the minimal change disease. Whereas in your adults, it is the membranous glomerulonephritis, which is the most common cause of nephrotic syndrome in adults. And here it is characterized by membranous. If you remember the nomenclature which we have talked about in previous class, it means that there is a thickening of the capillary basement membrane, glomerular basement membrane, and then electron microscopy shows that there is immunoglobulin deposit along the subepithelial side of the basement membrane. And here 85% of the cases are idiopathic. Idiopathic means cause not known, and only 15% are secondary to the use of the drugs like captopril, NSAIDs, and they can be secondary to certain tumors, certain infections, and also thyroiditis. It is a chronic immune complex mediated disease, and it is having the same etiology what we talked about in the previous class. That is, it can be because of your antibodies which are intrinsic or planted, which it can be immune complex deposits, or it could be a direct damage by the activated complements. And coming to the light microscopy, here we have a uniform diffuse thickening of the glomerular capillary walls. Right? See, this is the thickened glomerular capillary wall. This is to show you a normal one. Compare this with this. We are having a thickening of the glomerular basement membrane, whereas the number of the cells remains same. Okay? This is the capillary patent capillary. This is the nucleus of your endothelial cell, and this is your basement membrane which has been thickened, membranous glomerulonephritis. This is a PAS stain to show you the increase in the basement membrane, thickening of the basement membrane. This is again the PAS stain. So when you see it under electron microscopy, they found that there were electron dense deposit between the basement membrane and the epithelium. So epithelial side we are having the immune complex depositions, and they called them as spikes and domes. Okay. See here the black deposits here on the epithelial side of your basement membrane. If this is the basement membrane, this is the endothelial side, and this is the epithelial side. So subepithelial basement membrane deposition is what we see in your membranous glomerulonephritis. So here are your deposits. Granular deposits contain both immunoglobulins and the complement. I think most of the cases where we were talking about immunofluorescence and we were talking about the immune deposits, they are immunoglobulins as well as complements. Yes, this is the granular base thickening, granular deposition of your immunoglobulins. Now, what are the clinical features in membranous glomerulonephritis? The most common presentation is the nephrotic syndrome. In 15% of the cases, you can have a non-nephrotic proteinuria. That means the proteinuria is less than 3.5 grams per deciliter. They are non-responsive to corticosteroids, and usually they will also have hematuria and mild hypertension in the cases of membranous glomerulonephritis. And usually it is a indolent course, and there is a persistence of proteinuria in more than 60% of the cases, and of this 10% will die in 10 years with chronic renal failure. Spontaneous remission is more common in women compared to men. So what is nephrotic syndrome? It is massive proteinuria to the range of 3.5 grams more than per deciliter per 24 hours of the urine, with hypoalbuminemia, lipiduria and edema. And histological lesions causing nephrotic syndrome, it is the minimal change disease, diffuse mesangial hypercellularity, and membranous glomerulonephritis, focal segmental glomerulosclerosis. And so during the course of the clinical follow-up, what is that you check for in these patients? What is that you need to check for? One is whether the patient is having microscopic hematuria, because when you are having microscopic hematuria, it is most likely that the cases are not minimal change disease and their response to therapy is less, and the prognosis, or that is the likelihood of these patients going into renal failure, is more. Right? The second one is they are having excess of susceptibility to infections and also renal vein thrombosis. So what is the importance of CUE in the cases of nephrotic syndrome? If you are having microscopic hematuria in the cases of nephrotic syndrome, it is most likely that it is other than minimal change disease. That is what we need to remember. So if you look at all the glomerulonephritis or the glomerulonephritis, the minimal change disease, membranous glomerulopathies and your focal segmental glomerulosclerosis, they come into nephrotic syndrome. Minimal change disease is a pure nephrotic syndrome, and then membranous and focal segmental we have microscopic hematuria, mesangial-proliferative, membranoproliferative, and then diffuse proliferative. All of them are having nephritic syndrome. So this is to show you a relationship, how the nephritic syndrome is probably a more severe damage compared to the nephrotic syndrome. Okay. So causes of the nephrotic syndrome are primary and secondary. Primary, we are having 4 entities: minimal change disease, diffuse mesangial hypercellularity, focal segmental glomerulosclerosis, and then membranous glomerulonephritis. In secondary, we are having diabetes, mellitus, amyloidosis, SLE and drugs. Now, before closing the nephrotic syndrome, we need to know what is a diabetic kidney, because this is one of the most common causes of secondary causes of nephrotic syndrome. So what is diabetic nephropathy? This is usually seen in patients who had diabetes for more than 10 years, and it is more frequent in type 1 than in type 2 diabetes, and 30% of the diabetics they die of renal failure in cases with chronic renal failures. And then the nephrotic syndrome is reported in almost up to 40% of the diabetics, and 40% of the diabetics have hematuria. So this is the problem which we have in this is the range of the problem which diabetics have, and the nephropathy is one of the most common complication of diabetes. So when do you call it as a diabetic kidney disease? In diabetic kidney disease, we have glomerulosclerosis, arteriolosclerosis, pyelonephritis and papillary necrosis. All these things are present in diabetic kidney. This is pyelonephritis, that is, there is pus in the pelvises, and then we are having capillary necrosis, papillary necrosis in the cases of diabetic kidney. And diabetic glomerulosclerosis, that is, thickening of the basement membrane is seen, and this is due to the non-enzymatic glycation of the basement membrane, which leads to thickening of the glomerular basement membrane, which makes it leaky and causes proteinuria. And what are the lesions which you find in cases of diabetic glomerulosclerosis? One is diffuse global thickening of the basement membrane. That is the whole, just like the membranous glomerulonephritis, we have a diffuse thickening of the glomerular basement membrane, or we can have nodular sclerosis, or it could be arteriolosclerosis, or just trapping of the serum proteins. And then 50% of the diabetics will have proteinuria, and 30% of them will have end-stage kidney disease. So the most striking lesions, renal lesions found in cases of diabetic kidneys are in the glomerulus or in the blood vessels, and in the glomerulus it is seen as diffuse glomerulosclerosis or nodular glomerulosclerosis or an exudative lesion, and thickening of the glomerular basement membrane is the most consistent finding in the diabetic nephropathy. Coming to nodular glomerulosclerosis, it is also called as Kimmel-Stein-Wilson's lesion, and it is characterized histopathologically by it is the characteristic histopathological lesion of the diabetic glomerulosclerosis, and this is a acellular nodule of pink area which is present in the intercapillary region. See, these are the capillaries, and we are having a deposition of extracellular matrix in between the intercapillary regions, right? So, large acellular nodule that is located in the intercapillary region. If you look at that, you are not having any cells in that. How do you know that there are no cells? No blue dots. Blue dots are what? They are the nuclei. So, this is nodular glomerular sclerosis. So, what are these nodules? They are eosinophilic. Eosinophilic means pink in color. Argyrophilic, that means they are attracted to silver stains. They are PAS positive. They stain green with Mason's trichrome, blue with Mallory stain, and ultrastructurally they are composed of the masses of extracellular mesangial matrix. Yes, this is the PAS staining. All this. Yeah. Now, so what is nephrotic syndrome? Nephrotic syndrome is primary and secondary. Primary is because of minimal change disease, most common minimal change disease, and focal segmental glomerulosclerosis or membranous glomerulopathy, and diabetes and amyloidosis are the most common causes of nephrotic syndrome. Now, let us compare nephritic syndrome and nephrotic syndrome. This is very important and it will help you in your clinics. So, please learn this little carefully. Okay, nephritic syndrome is because of hematuria. We are having hematuria, proteinuria, oliguria, decrease in glomerular filtration rate, and azotemia. Increase in creatinine in 1 is called as azotemia. There is edema which is mild, and usually they have hypertension. Whereas nephrotic syndrome, you are having a nephrotic range proteinuria which is more than 3.5 grams per 24 hours. This leads to hypoalbuminemia, edema, hyperlipidemia and lipiduria. Usually, though there is lot of edema and lot of proteinuria, there is no no reduction in your glomerular filtration rate in these cases. The burn and creatinine are usually normal. Okay, so minimal change disease and membranous glomerulonephritis. In children, 75% of the cases are minimal change disease, whereas in adults it is the membranous glomerulonephritis which causes nephrotic syndrome. Right? So let us meet in the next class, where we will discuss about the tubulointerstitial diseases and also about the tumors which we encounter in kidneys.